fine. I'll be talking about what role we have in nuclear medicine for imaging or localizing the parathyroid adenoma in primary parathyroid lesions. So as you know, most of the primary hyperparathyroidism is caused by a solitary parathyroid adenoma, about almost 85% of the time, and about 5% of the time it is caused by dual adenomas, and about 10% by a parathyroid hyperplasia. And in this situation, it is usually associated with a familial situation, like a familial hyperparathyroidism in association with MEN 1 or MEN 2A or parathyroid jaw syndromes. And very rarely, less than 1%, it may be because of a parathyroid carcinoma. Now, we are called upon mainly to localize once the diagnosis has been documented biochemically. We are called upon to localize the adenoma site preoperatively to enable minimally invasive parathyroid surgery, which seems to be the norm now, to prevent surgical failure by preoperatively localizing more than one parathyroid adenoma, which is usually the cause of surgical failure. We are not very good at this, but we are getting better with the help of new techniques. We are also there to prevent surgical failure by preoperatively identifying ectopic sites of adenoma, which can be present in a fair number of people, and the nuclear techniques are fairly good for this. And nowadays, during surgery, we can help the surgeon with the help of an intraoperative gamma probe to enable the correct and complete removal of the adenoma. This probe is now available, and I believe many centers in Mumbai are using this. And after a failed surgery, for planning the resurgery, again to localize why we have missed the initial adenoma. Now, two major tracers are available to us for localization of this parathyroid adenoma. All of you are aware of the technetium sestamibi or methoxyisobutyl isonitrile, and the technetium labeled tetrophosphate. Basically, these are not parathyroid specific tracers, but they are picked up by metabolically active cells. Basically, these tracers go to cells which are rich in mitochondria, and they go to cells which are highly vascularized. So these two attributes have to be present before a sestamibi scan becomes positive. And they are also taken up by various other tumors. They are taken up by the myocardial tissue. It's usually used for a myocardial perfusion scan, and a lot of breast cancers, myeloma, and brain tumors. We use it in the setting of a parathyroid gland because parathyroid adenomas tend to be highly vascular, so that the delivery of the isotope is there. The parathyroid adenomas contain oxyphil cells, which are very highly rich in mitochondria. So this is where the tetrophosphine and the MIB go and localize, and this is how we are able to pick up. Because of the high vascularity, because of the high content of mitochondria, we are able to have high retention of technetium sestamibi in parathyroid tissue. An immediate corollary to this is that if the parathyroid adenoma is poor in oxyphil cells, then we are going to miss it. So this is one of the reasons why we may get a negative parathyroid scan in an oxyphil poor parathyroid adenoma. So what basically we do when we inject the technetium labeled sestamibi, we take multiple images. You can see here the patient has been injected. The tracer has gone nicely to the normal thyroid gland. It has gone to the submandibular and the salivary glands, parotids. And as about 20 minutes later, the maximum uptake is seen in the thyroid gland. An important fact to appreciate is as time goes by, the normal thyroid gland loses the technetium sestamibi. It gets washed out from the normal thyroid gland by about 1 to 2 hours. You can see here at about 60 minutes, there's hardly any MIB left in the thyroid gland while it remains in the submandibular and the parotids. So this is the basis for the parathyroid scan. It washes out from a normal thyroid gland. However, it is retained by a parathyroid adenoma. So this differential washout forms the basis of what we call as a dual phase parathyroid imaging. So we can use a single tracer. These are the various techniques we use. We can use a single tracer, dual phase planar imaging. That is, we inject the tracer, we take immediate image, we take a delayed image, the parathyroid adenoma stands out on the delayed image because the gland doesn't lose it and the rest of the thyroid gland disappears. So this is what we find. But what you should appreciate is that many times the thyroid gland itself is diseased. And that's why we must be able to know whether the normal gland is there in order to compare with the parathyroid gland. So what we do, we use a dual tracer. We inject technetium pertechnetate, which we use for a regular thyroid scan. All of you know the isotope thyroid scan. So we first perform a regular technetium pertechnetate thyroid scan. This gives us the structure and function of a normal thyroid gland. Then we wait for a while and then inject the technetium MIB. So we have a dual tracer. Then we again take a delayed image to allow the technetium MIB to be retained in the parathyroid adenoma. So a dual tracer subtraction planar imaging is the next imaging technique. And finally, what every department should use now as the state of the art is a dual tracer, dual phase SPECT CT. Most of these techniques which I've shown you are planar. The patient is just lying under the camera, the detector is in front of him, and we are taking the images. But now we are adding a SPECT CT technique to it. We take tomographic images, so we get three-dimensional views of the parathyroid and the thyroid gland, and we combine it with a full-blown CT with or without contrast, depending on how sophisticated we want it to be. Usually it is without contrast. We get an excellent anatomy of the parathyroid and the thyroid region. So now at this point of time, if you want to do a parathyroid scan, it should be a dual tracer, dual phase SPECT CT scanning. Having said that, you can see here, technetium system EB parathyroid scan, single tracer dual phase imaging. You can see we have injected the patient at 20 minutes. You are seeing the right lobe of the thyroid, early phase. Both the thyroid and the parathyroid gland pick up the technetium MIB. And a delayed phase, the thyroid gland loses the technetium MIB, but the parathyroid gland retains it. So you are seeing a very nicely delineated left lower lobe parathyroid adenoma in this scan. Then we have a dual tracer. When we are first inject the ordinary technetium pertechnetate scan, then we inject the MIB scan and we compare the two. Now technetium pertechnetate goes only to the thyroid gland, while technetium MIB goes to both the thyroid and the parathyroid. So when we subtract the technetium image from the MIB image, what is left is the parathyroid gland. You can do this as a computer-based subtraction, or you can do a visual subtraction. You can see visually also there is something below the right lobe of the thyroid gland. When we subtract it, it stands out very well. So this is a dual tracer subtraction scan, which we normally do. And I'll show you a nice cases now. A 37-year-old female presented in emergency in a state of delirium. In ICU on investigation, there was a hypercalcemic crisis. The serum calcium was 14. PTH was more than 2000. And you can see here a simple pertechnetate. It's always a dual tracer two-phase scan which is to be done combined with a SPECT CT. This is the point I'm going to reiterate again and again. You can see here a technetium pertechnetate scan and a MIB scan. You can see on the right side, the right lobe of the thyroid looks normal, and on the MIB scan, it washes out pretty well, quickly washes out as time goes by. But on the left scan, you can see this huge intense uptake of tracer is there, which is retained at the 1 hour delayed image. So it was a huge left lobe, behind the left lobe parathyroid adenoma. And because it was behind the left lobe, it was causing attenuation of the counts, and we are getting a sort of a reduced uptake on the technetate scan. You are seeing a less uptake in the left lobe of the gland because this adenoma was right behind and it was preventing it. And another important role is ectopic tissue. Up to 16%, we can get ectopic tissue all along this, from the carotid bifurcation all the way down to the aortic arch. Usually about doesn't go below the carina. So in all our scanning, we'll always scan from the carotid bifurcation all the way down to the carinal level, and we'll always pick up wherever the ectopic tissue is there. You can see here it's in the region of the left carotid sheath. Here it is in the region of the mediastinum, an ectopic tissue. Very nicely picked up. I can see the technetium maybe has gone to the heart. It has gone to the submandibular salivary glands. So in the systemic review of the diagnosis and treatment of primary hyperparathyroidism, they have found that the sensitivity for single adenoma is fairly high. For hyperplasia is much less, around 44%, and for a double adenoma is around 30%. For some reason, we do not pick up multiple adenomas because the dominant adenoma seems to be picking up the tracer, and the other adenomas, though they do pick up in a very low level, so we probably miss them. But now with the combination of the CT technique along with our scan, we are also picking up this multiglandular tissue. This is the diagnostic accuracy of, it's a review of literature where all modalities have been compared, Sesame B, SPECT. Mind you, over it is written Sesame B, SPECT CT. This is now what we are doing. And with Sesame B, SPECT CT, we are getting high values in the high 90s. 4D CT is coming in a big way now. It has also got a very high sensitivity and specificity, but one must note that the radiation exposure is phenomenally high. The thyroid gland gets 50 times more radiation with a 4D CT as compared to a Sesame B SPECT CT because of the multiple phases that they take. So in a young person, you have to be very, very careful while doing a 4D CT. In an elderly person, 50 years, 60 years, and the diagnosis is very important, you can do the 4D CT, but you are getting a very comparable sensitivity and specificity by using Sesame B SPECT CT now. Mind you, it has to be now a Sesame B SPECT CT, where you have now a combination of both the anatomy as well as the functional. So how good are we? What are the pitfalls? When do we get negative scans? We get negative scans when the parathyroid adenoma is small. If it's a large adenoma, more than 500 milligram, the sensitivity is very high. If it is less than 500 milligram, the sensitivity falls. As I've already told you, oxyphil poor adenomas will not retain much. They do not have much mitochondria, so they will not retain the tissue, the Sesame B a lot. A quick washout can occur very rapidly. Those, P glycoprotein is expressed on in the cells, and the P glycoprotein throws the Sesame B out. So if there's a high expression of P glycoprotein, then the Sesame B will be thrown out and you will miss the adenoma. So now what we do is we take dynamic images. I'll show you a few examples. If you have a concomitant thyroid disease, if you have thyroid cancer, that cancer will also pick up maybe and look very hot. And unless you have done a CT along with it, you will not know whether it's inside the thyroid or outside the thyroid. So concomitant thyroid disease can be a problem. Functionally suppressed adenoma in a patient who has been given cinacalcet may suppress the normal parathyroid adenoma and you may miss it. Calcium channel blockers for some reason have been known to show reduced uptake on a parathyroid adenoma, so probably you may want to stop them. Hyperplasia and multiglandular disease, as I told you, there are multiple glands. For some reason, the dominant gland picks up and you may miss the others. And hyperplasia, when all the glands are picking up equally, you may not pick up a discrete adenoma. What you will get is a delayed washout, and the gland, instead of washing out completely, is faintly seen. And that may be a clue for hyperplasia. Normally, a technician, maybe the thyroid is not seen at 2 hours. But if you're still seeing it faintly, your mind may be raised. The doubt may be raised that you're dealing with a hyperplasia if you're not seeing discrete foci of retention. As I told you, false positive lymph nodes which are malignant may pick up maybe, and lymphoma, solid thyroid cancers. But all these in the context and by looking at all the features, you can easily distinguish between these two. So that's why when we do a thyroid maybe imaging, we do a dynamic imaging so that when we inject under the camera and we take rapid views, we see this tracer uptake coming up below the left lobe. And if we don't take these early images and if they wash out very rapidly, then we are going to miss these early changes. So we always take early images to look at the early uptake and late images to pick up both the early and late. So we will not miss out adenomas which are rapidly washing out, and we'll pick up adenomas which are not washing out. So importance is to combine functional imaging and anatomical imaging. There's enough evidence now that combination of scintigraphy, Sesame B scan, and ultrasound, when they are both combined, when they are both concordant, it has the highest sensitivity. When we combine a SPECT CT we are using the same thing. We are using the anatomical imaging and the functional imaging. So SPECT CT is also giving you a fairly very high sensitivity and specificity. So when you add SPECT CT to a planar scintigraphy, this is what you are getting the advantage. You can show here, over here, I'm showing you a case where you are seeing an uptake in the right lobe of the thyroid on the per technetate scan. You can see at the upper lobe, upper pole of the thyroid, there is an uptake which is not seen on a per technetate scan. You can see here on a tomographic image, a very nice focus here, but I don't know where it is, whether it's inside the thyroid or outside the thyroid. So when I combine it with the CT, it is clearly seen over here. You can see a nice lesion here, upper pole of the right lobe of the thyroid gland, using nicely with the SPECT image. And so the sensitivity of SPECT CT makes it really very high.
Deliver some comments over the solution, sir.
So here you are finding a 61-year-old female was found to have increased creatinine and PTH level. She was asymptomatic. Dr. Chadda has just spoken nicely about asymptomatic hyperparathyroidism. The neck ultrasound, there was no parathyroid adenoma seen. She was medically managed with injection zoledronate, and in 2018, the PTH rose very high, and we were asked to do a scan. And you can see here nicely this hot focus here in the anterior mediastinum. And since we also do a CT along with it, the SPECT CT showed this lesion very nicely in this very fusing over here. This was a parathyroid adenoma, which was in the anterior mediastinum, beautifully picked up, and it was not in the neck, so it was ultrasound could not show anything. So here was a 34-year-old male, recurrent renal calculi, weight loss, body ache, very high PTH, serum calcium of 10.2. We always do a technetium per technetate first, then a sestami B. And we look for the congruence. You can see the right lobe is fairly congruent over here, the right lobe of MIB and right lobe of technetium, but the left lobe is showing intense uptake on the MIB, which is retaining at 2 hours. So this was a definite parathyroid adenoma involving the left lobe. And on the SPECT images, you can see there are multiple other areas which are very hot. And you can see here this huge parathyroid adenoma in relation to the left lobe. In addition, look at these ribs, look at the clavicle. There were multiple brown tumors which were there in the bones, which were nicely picked up by the sestami B scan. So when we get 1 or 2 lesions like this, we always do a whole body sweep to look at the extent of the brown tumors. Here was a 49-year-old male, generalized aches and pains, again high calcium, high PTH. But if you look at it carefully, it is not very clear over here. This is the per technetate image, and this is the sestami B image. You can see that there is something here at the lower pole of the right lobe is blank on the technetium image, but it is full on the sestami B image. So we suspected a right lower lobe parathyroid adenoma here. Also, the upper part of the left lobe was blank, while the upper part of the left lobe was showing hot on this sestami B image. So when we fused it with the CT, we are finding very nicely an upper left lobe parathyroid adenoma, as well as a right lower lobe parathyroid adenoma. So we've nicely picked up multi-glandular disease over here because we could combine the CT along with it. The CT clearly showed multiple adenomas which were fusing beautifully with the hot areas seen on the MIB SPECT. So SPECT CT allows localization of multiple and small adenomas. Most of the earlier studies were only SPECT. Now SPECT CT, we are having a very powerful tool where we combine both anatomy and physiology. Either you combine it with ultrasound, which is usually done. Ultrasound is the first thing to be done. And when we do the sestami B, there is concordance. But in the sestami B scan is now routinely a SPECT CT. So you are getting anatomy also very nicely. Here was a 51-year-old female. She showed an adenoma in relation to the left lobe of the thyroid. She denied surgery, like the case which Dr. Chadda said. She was started on tablet Cinacalcet. She was now asymptomatic. You can see on a scan, we are not seeing anything really significant. And on the CT scan, we picked up this adenoma. But because of the Cinacalcet, this adenoma was not picking up any activity. So you must be aware that system EB uptake will be suppressed due to cinacalcet, and you will not call it, because you are aware of the background, you will make a proper appropriate interpretation. Parathyroid carcinoma. Here is a technetium scan. Both the lobes of thyroid are very good and normal. On a MIBI scan, the upper lobe of the left lobe, there is this hot spot, which turned out to be a huge parathyroid adenoma. And with a PTH more than 2000, it turned out to be a parathyroid carcinoma. On a SESTA-MIBI spec CT, we cannot say whether it's a carcinoma or an adenoma. It's a histological diagnosis, but we can localize it so beautifully. Many times, the upper lobe adenomas can be prolapsed. They may go behind and be presented as posterior mediastinal structures. So we have to be careful about lower lesions. What we see, they may not be lower pole adenomas. They may be actually prolapsed upper pole adenomas, and they usually occur in the mediastinum just behind in the retro esophageal groove. Most of the ectopic adenomas are in the anterior mediastinum because they follow the pathway of migration. They migrate with the thymus, and they go down and follow where the thymus goes. So these are some of the points one has to bear in mind. You can see here the last one or two slides, a case of hypothyroidism on Eltroxin, weight loss, and you're having a high PTH, creatinine was normal. Ultrasound showed a well-defined hypoechoic lesion along the posterior margin of the left lobe. You can see here when it is washing out, there is some uptake in the region of the left lobe, which is, and when we did the CT part of the study, surely enough, we are seeing this very well. Mind you, there is disease in the thyroid also. It is doesn't have much iodine content. Otherwise, the thyroid will glow as white on a non-enhanced CT. All these are unenhanced CTs. So you can see here, there's a lesion here, which is faintly picking up the isotope. So we still called it as a parathyroid adenoma because of the CT part of the study. And there's no doubt when we combine both, even if we don't get much uptake in that lesion which is seen on CT, we will call it as a parathyroid adenoma because many of these lesions may not have too much of oxyphil content. And in very much doubt, if we have, then we just give a contrast. And we can see the typical lesion which is enhancing on the contrast CT, washing out on the delayed image, and is hypodense on the non-contrast image. So we can, in very difficult cases, very rarely, where we are at a loss, we can combine a contrast injection along with the SESTA-MIBI spec CT we are doing and give you the answer. There are other tracers for parathyroid imaging, carbon-11 methionine and fluorine-18 fluorocholine, which are available to us. They are not available in Bombay. In India, they are available in Bangalore and in SGP and Postgraduate Institute at Chandigarh. The importance of fluorocholine is that it's a very nice tracer. Choline is a component of membrane phosphatidylcholine, and there is increased cell proliferation and metabolism in adenoma or hyperplasia, and upregulation of choline kinase activity, and it causes increased choline uptake. So many times where SESTA-MIBI is negative, the choline scan will be positive. You can see here two very nice adenomas are picked up here. You can pick up hyperplasias also very sensitively with choline. And this was a review article in 2019 where the sensitivity is fairly high, 96, and detection rate per lesion is in the 90s. When it becomes routinely available, this will become a sort of a final arbiter for presence of parathyroid adenoma. Right now, only available at 2 places in India, but we don't require it so regularly. We do fairly well with the dual phase, dual tracer, dual phase spec CT protocol, which we are following. And finally, the intraoperative gamma probe, where you can find out the surgeon can localize we inject the SESTA-MIBI just before the surgery, and it helps to localize small and ectopic parathyroid. Surgeon can remove it, and we can see whether the counts have disappeared from that bed. That means the surgeon has done a good job. He's removed it completely. So to summarize, technetium SESTA-MIBI tetrophosphine parathyroid scanning is a time-tested method for evaluation of hyperparathyroidism. It has high sensitivity, high negative predictive value. Fusion imaging with spec CT, that is the bottom line, has now significantly enhanced sensitivity to more than 95%. Correlation with ultrasound MRI increases accuracy in difficult cases, and 4D CT can be done in very difficult cases. I thank you for